Chapter 51 is nursing care of the child with a musculoskeletal disorder. This isn't a long chapter, at least the things we're going to cover aren't quite as extensive as some of the other chapters. The first thing, or the chapter starts out with talking about casting. This probably is going back to some of your earlier nursing classes as far as, a lot of the principles of casting and the purposes are the same in your adult patients as they are in the pediatric population. But again, just a few things to review related to casting as far as nursing considerations. Certainly, when the cast is still wet, supporting it with a pillow. When you're moving it, obviously holding or using the palms of your hand so you're not forming any indentations with your fingers. Elevating the casted extremity to limit any edema or swelling. Certainly your neurovascular checks become important as well. Pedaling the cast, or the cast edge, I should say, to prevent any irritations. After the cast is dry, certainly you could apply ice packs to decrease any swelling that the child may have. You have your nursing diagnoses and more specific interventions that start on page 1613 in your textbook and then continue on through the next page. So again, certainly I would just encourage you to review that. Probably one thing just to mention, and I know the book probably talks about this as well, when we're thinking about casting younger children who may not be able to tell us if the cast is too tight, that certainly talking to the parents about, monitoring or things to look for that may indicate there's some swelling or some problems with the cast, again, that a child may not be able to report. We worry about young children putting things down inside the cast, little matchbox cars or other small toys that may fit down in the cast. So, discussing that with the child, again, as appropriate for their age, but certainly with the younger children, we'd want to talk to the parents about keeping track of that as well. And again, there's a family teaching box also on page 1614 that you can review as far as things to talk about with the child and their parents when they're going home with a cast on. There's also information about traction in this chapter as well. The purpose of traction being to correct dislocations or fractures. It can also immobilize fractures as well. With traction, again, remember you can have two types. Skin traction, in which the traction is applied directly to the skin, and then skeletal traction, in which the traction is applied to the bone itself, either through wires or pins that have been inserted into the bone. On page 1617 in your textbook, you have pictures of different types of either skin or skeletal traction. When we're thinking PEDS, one of the types of skin traction that we think about being used sometimes is Buck's traction. And you have again, a picture of that in your textbook. Again, it's typically used, as the book says, for fractured femurs in children under 2 years of age. And again, the note in your textbook that this type of traction we really don't see being used a whole lot anymore because of the problem with of pooling of blood at the hip area. Again, as your book talks about on page 1616, I can tell you from personal experience, I rarely see this used anymore. But again, you may come across this on an exam. So again, just knowing that that is skin traction, again, typically used for fractured femurs. Another type of traction that your book doesn't actually have a picture of it, I don't believe, but that we do see sometimes in peds is something called Bryant's traction, Bryant. And I didn't put this up in the slide, but just to make a note about this, this type of traction, typically used for children under 3 years of age. The child has to weigh less than 35 pounds. They will use it for a child who has a fractured femur. On some occasions, you might see it used with congenital hip dysplasia as well. Basically, what happens with Bryant's traction, both legs are placed in like a skin traction. The child lays with their hips flexed at a 90-degree angle. The knees are extended, and the traction actually lifts the child's buttocks slightly off the mattress. This is why this is only used in children up to 35 pounds because it can cause some problems with hypotension if it's used in children older than that. The other, you have pictures of Russell's traction, letter B again you can see with the lower leg. Dunlop's as well, and I believe you have a picture of that, letter F. Dunlop's traction is typically used for arm fractures, fractures of the humerus. The arm is kind of flexed and then suspended horizontally. This can either be skin or skeletal traction. And just some nursing interventions to think about regardless of what type of traction is being used. Certainly neurovascular checks with the involved extremity, checking temperature, color, any pain or tingling sensations, edema, pulses, cap refill, all those things would be important as well. Making sure that alignment is maintained with that affected extremity, certainly assessing pain, ensuring an adequate diet also during the healing is important, and other problems, complications that may come from immobility. Monitoring skin integrity, bowel and bladder function, encouraging range of motion exercises as appropriate based on the child's condition as well. So again, just some things. And also with the skeletal traction, we have to be concerned about the pin insertion sites. Make sure we're monitoring those for any signs or symptoms of infection. Pin care as appropriate, also with skeletal traction. Leg calf purse disease is another disorder that is included in this chapter, and basically what this is as it says on the slide there, where there's a necrosis occurring within the head of the femur. So if you think about that head of the femur, inside it's basically becoming necrotic, as it says. Symptoms that the child is probably going to present with, pain in the hip area. Parents may notice that or say that they've noticed that the child is limping, and that limping tends to be aggravated, as well as the pain by activity, and then they get some relief with rest. Child may report that they have a lot of stiffness in that joint in the morning, or maybe after they've been sitting for a while. There may be limited range of motion as well, and we may even see where it looks like that affected limb is a little bit shorter. This disease kind of has a long progression in terms of it goes through 4 stages which are outlined in your textbook, and these stages, it's not like these stages just last a couple weeks. Some can last for a year or longer. So a child can recover from this, but again, this is definitely kind of a long-term disease that they're going to be dealing with. And the stages of the disease are listed there again, where you kind of have that necrosis occurring, and then gradually by stages 3 and 4 where you're getting new bone formation. The key with management of this is keeping pressure off of that head of the femur, because again, if you think about the inside of that head of the femur becoming necrotic, if you put pressure on it, you know, what's going to happen? Think about the shape. It'll, as it says in your book, it kind of may take on a mushroom shape. If we start getting that change occurring, that's going to be permanent. And even after the disease has run its course, the child's probably going to be left with some problems in that hip joint. So really the key with management is keeping pressure off of the head of that femur. That can be take the place of casting, perhaps, traction. They can go in, as your book says, and do like an osteotomy, where they can put like kind of a pin in there to support that, so that the child can go back to some weight bearing, perhaps, without any damage. So again, it's not a real common disorder, but certainly is a very serious one, and again, one that the family and child will be dealing with for a significant length of time. Osteomyelitis is, as it kind of sounds, an infection of the bone. Can be caused by different microorganisms. Typically, we think of this as a bacterial infection. Staph aureus, probably the leading bacterial cause. With this, sometimes we'll see the Haemophilus influenza as well in younger children. Probably not so much anymore because of now children getting that Haemophilus influenza type B vaccine. But that bacteria gets to the bone through the bloodstream, again, or from perhaps another type of infection, if there was maybe some type of penetrating wound that, again, may introduce the bacteria into the bloodstream. If we think about assessment or what we typically see, again, oftentimes there's some history of trauma, perhaps to the bone. Symptoms in the beginning may be fairly general, as far as maybe just some general malaise, fever, irritability, but also probably going to notice that the child's going to report pain, tenderness, swelling at the site of the infection. There's a possibility they may have some decreased mobility with that affected extremity. Probably going to see some increase in white blood cell count. Blood cultures will also be positive. As far as therapeutic management, IV antibiotics, sometimes for as long as 6 weeks, will be ordered. Child will not have to stay in the hospital for those 6 weeks. Probably may go home with some type of INT, maybe a PICC line, then with just a home nurse following up with administration of those IV antibiotics. But again, you're probably looking at a range of about 3 to 6 weeks on IV antibiotics, and then possibly a course of oral antibiotics following the conclusion of the IV antibiotics. In general, immobilization of the affected extremity. Possible they may have to do an incision and drainage on that site as well. Dressing changes probably would be a part of the care as well. Children with sickle cell anemia that we talked about back in the hematology chapter, there does tend to be a higher incidence of osteomyelitis in that particular population. Just kind of as a little side note or FYI. And again, you have a nice nursing diagnosis with some interventions listed as well for osteomyelitis on page 1623 in your textbook. The next thing to talk about is scoliosis. As it says on your slide there, scoliosis is a lateral curvature of the spine, can be functional or structural. Functional means that the curvature of the spine is occurring secondary to something else that's going on. That might be uneven leg lengths, perhaps, in the child, maybe the presence of some type of tumor perhaps that's causing the spine to curve. But probably in most cases of scoliosis we see it's just structural, where it's just kind of idiopathic. We don't really know why it occurs. There's thought to perhaps be some familial tendency to it. But again, it just kind of, the spine just starts curving for no particular reason. How would you conduct a screening for scoliosis in a child? Probably a lot of you may remember back in junior high, perhaps in gym class, maybe the school nurse or someone else in the school doing screenings for scoliosis. When we're screening for scoliosis, what are we going to ask the child to do? We're going to ask them to stand up with their back to us and with their arms down at their side. And what are we looking for? Well, we're looking to see, do their shoulders appear to be of even height? What about their arm lengths? Do those appear to be even? Looking at their hip area, do their hips appear to be even? And then just kind of taking a general look at the spine to see, does it seem to be straight? The next thing that we would ask the child to do is to bring their hands, or extend their hands out in front of them, their arms, and bend at the waist. Oftentimes as they bend forward at the waist, you will see that curvature become a little more prominent, where one scapula oftentimes appears a little bit higher than another. A lot of times you might see a school nurse using something called a scoliometer, where it almost, I guess the best way for me to describe it to you is think about like if you do any projects around your house, hanging pictures or other things, and you want something to be level, and you use one of those little levels and you look to see, is that bubble right in the middle? A scoliometer is kind of that same type of device and can be held at different positions along the child's back while they're bending over, and that will show you again if there's any type of curvature. This picture you also have in your textbook on page 1626, and again you can see how it's not a great picture, but it does kind of show you how, as that child would be bending forward, that one scapula appears higher than the other. Now, to think about some therapeutic management, a lot of it is going to depend on the degree of curvature that is noted. And again, just to say before we go into any more about therapeutic management, girls tend to be affected with this more so than boys. And to go back to thinking about our screening, we usually, I mentioned, like you may remember back from junior high, well, that's a lot of times where the screening is taking place, in that adolescent time frame, because again, remember, birth to a year of age is the most rapid time of growth. The second most rapid time of growth is in adolescence, and again, that's a lot of times where we will see that scoliosis first appearing, is in adolescence with that rapid growth spurt. But anyways, back to therapeutic management. As your book says, if the curve is less than 20 degrees, probably no treatment will be recommended. They may continue to monitor the child. I know it says in your textbook until the child reaches about 18 years of age. That may vary somewhat. What they would be looking for, again, probably doing x-rays during that time frame and kind of watching to see, is the curvature getting any worse? If the child has kind of reached most of their adult height, a lot of times we won't see that curve get any worse. So again, less than 20 degrees, typically no intervention will be done. Now, if we're getting into the area where it's greater than 20 degrees, one of the things that they might do is bracing. And you have a picture on page 1627 of a child, or I should say a teenager, being fitted with a TLSO brace, as it's usually called. Now, it's spelled out in your textbook for you what TLSO stands for: thoracic, lumbar, sacral, orthotic device. You can see it kind of fits right up under almost the child's arms and extends down into the hip area. This, with wearing the brace, teenager has to wear this brace pretty much around the clock. They can take it off for bathing and showering, but otherwise they're going to pretty much have that on all the time. As it says in there, the brace, you would obviously wear it over some kind of light t-shirt, just to prevent any skin problems with that. Initially wearing it, as they're getting used to it, it may cause a lot of, or there may be some pain or discomfort as the child gets used to it. Honestly, I don't know that they ever get totally used to it, but that, sorry, I lost my, but that, again, it's something that, we kind of have to monitor to make sure the fit is okay, that they're not, again, getting any skin excoriation, those types of things. Just a few other things is thinking about the bracing as well, just to mention, and again, you have more information about some of the issues with putting a teenage girl, typically a girl, that would be getting one of these braces, and you tell them this is something they have to wear basically 24/7. Again, it can come off when they're bathing, but otherwise it's on day and night. You can think about, obviously, even with clothes over top, it's going to be visible. We think about this age with self-esteem issues and kind of wanting to be like everybody else. We think about clothing styles now for teenagers, that's going to be a lot of issues for that teenage girl to deal with. And some of the other issues that sometimes come up with bracing is we can't necessarily guarantee to the child that this is going to correct that curvature. Hopefully it's going to keep it from getting any worse. Hopefully it will make it a little bit better. But it's not 100% guarantee. It's not to say that down the road they're not going to end up needing surgery for correction of that. And a lot of teenagers start hearing that and think, I'd just rather have the surgery than have to wear this brace for the next year and a half. So that may be other issues to think about as well. And then one other thing that they talk about in here too is that even after the child has kind of reached adult height or growth has really stopped as far as their height, they may be allowed to keep the brace off during the day, but may still have to continue to wear it at night, as your book says, for maybe a period of 6 months or so. So again, this is not something that's just a quick fix, wear this brace for a couple weeks and you're good to go. It's definitely kind of a long-term issue that the child is dealing with. Traction may be something else that's used. You have some information on halo traction in your textbook. I would say we probably don't see this used a lot for scoliosis, but possible that we might see that halo traction being used. And again, you can just review that information in your textbook on 1629. Surgery. Oftentimes when we're getting cases of scoliosis where that curve is greater than 40 degrees, surgery is going to be necessary with inserting rods and wires in order to bring that spine into a more normal or straight alignment. Thinking about some pre-op teaching, certainly talking to a child about what they can expect after surgery. Certainly pain is a big issue. We can talk to them about things that will be done, a PCA pump, epidural perhaps, to assist with the pain that they're going to experience post-op. Talk to them about positioning and log rolling, and again, those other things that they may encounter during that immediate post-op period. Thinking a little bit about post-op care positioning and turning. You'll have to do log rolling with the child every 2 hours. They're going to be laying flat in that immediate post-op period. Certainly encouraging coughing and deep breathing. Use of incentive spirometer is going to be important. Monitoring for signs of blood loss is also important. Keeping track of vital signs. It's likely the child may have some type of drainage device from that surgical site. So again, monitoring for the amount of blood loss or any signs of hemorrhage would also be important in that post-op time. Pain management, as I mentioned earlier, probably we'd see a PCA pump. Again, we're dealing with an adolescent, so a PCA pump would be appropriate as well. Using an appropriate pain scale for the age and developmental level of the child, also important. Other things that we could also think of, the child's probably initially going to be NPO, probably have an NG tube. Strict INOs would be important. Frequent vital sign and neurological checks, also important. Probably be receiving IV antibiotics as well. So all of those things would be important in that post-op care. And again, this is the same picture that you have in page 1630. Again, it shows, you can see in the pictures with letter A, that spine, you can see the curvature and then how that spine is brought into a straighter alignment once those rods are in place. And again, letter B kind of shows the log rolling the child in that post-op period. Juvenile arthritis, or sometimes also listed as juvenile rheumatoid arthritis, is an autoimmune inflammatory disease. And surprisingly, it's actually one of the more common chronic diseases that we see in children, although we don't necessarily tend to hear a whole lot about it. There are kind of three ways in which juvenile arthritis can manifest itself, and you have a box on the bottom of page 1631 that looks at the different types: polyarticular, pocarticular, and systemic, and just with some information as far as joint involvement, what joints might be affected. Again, typically boys more than girls, except with the systemic, it's kind of equal with both of those. And then symptoms that you might see. Again, certainly some of the general symptoms that we think about, the stiffness and some joint swelling, changes with limited range of motion. Child may also oftentimes present with a rash. We might see just some malaise as well. And again, as your book says, a lot of times this diagnosis comes as a bit of a surprise, because we do generally tend to think of arthritis as being something that affects the older population as opposed to children. With this particular disease, again, it's a chronic illness, so there's really no cure. Our treatment is more in management of the symptoms, and you have all those symptoms that are discussed in your textbook: exercise, heat, splinting, nutritional issues, medications. Some of the medications that you might see being used, certainly NSAIDs, anti-inflammatories like Motrin, Advil. A lot of times in these you may see aspirin being used as well, and I know we've recently talked about Rye syndrome, but again, think Rye syndrome is typically associated with aspirin use in a child with a viral infection, which wouldn't be the case with this. Parents may be concerned if we prescribe aspirin, but again, sometimes looking at risks versus benefits of that particular medication, we may see it being prescribed as well. Anti-rheumatic drugs, again, for inflammation, may also be used with that. But again, in general, thinking about what would be some of the general things: pain, also in addition to the NSAIDs that may help with some pain as well. Heat, such as warm soaks, tub baths, whirlpools, Certainly avoiding over-exercising of those painful joints would be appropriate. Physical therapy may be appropriate as well. Again, splints. Promoting self-care in the child is important as well. Use of assistive devices so that they can be more independent certainly would be appropriate with that. And we'd want to try to encourage maximum independence on the part of the child. A lot of times these kids it may be difficult to do a whole school day. So again, I think as your book mentions, maybe an abbreviated school day, having the child take a tub bath in the morning, where that heat may help with some of their symptoms, and then they'll be better able to function when they get to school. Fractures are also included in this chapter. The picture on the slide also comes from your textbook on page 1636, just looking at common types of fractures that we might see in children, so you can kind of review and look at those pictures as well. Typically when we see fractures in children, a lot of times we're thinking about it's some type of trauma. Maybe they had a fall, were involved in a motor vehicle accident. Certainly we also have to be concerned with child abuse issues as well. So, making sure, does the injury seem to match the story and seem logical? And I'm not going to get into all those child abuse things, but certainly that's one thing, especially if you're working in the emergency room, that when we have a child coming in with a fracture, we'd want to know the cause of the injury. When we think about, assessment, or what are we going to see the child presenting with, there may be, depending on the type of fracture, some deformity noted of the extremity, swelling, bruising, tenderness, pain, maybe some loss of function as well. As far as nursing management goes, obviously we're going to probably be looking at, initially maybe immobilizing and elevating the injured limb or extremity if possible, applying cold to that injured area as well. Certainly x-rays are going to be a part of the management in terms of determining if there is a fracture. Other things nursing-wise that we'd think about would be checking those 5 P's: pain, pulse, pallor, paresthesia, and paralysis, including that in our assessment. Any change in as far as lack of sensation or movement, numbness, tingling. Analgesics would certainly be appropriate. Again, oftentimes with a fracture, then we could go back to what we talked about at the beginning of the chapter with what's going to also be included in the management, if it's casting the extremity, or perhaps if the child needs to go into some type of traction. And then we can also think about all the nursing care involved with those issues as well that we talked about at the beginning of the chapter.